hand in place, and I'm going to go from in the earlobe down to the xiphoid process. And then I'm going to take a piece of tape, and I'm going to mark at that point, and I know that's how far that I need to go down when I'm inserting the NG tube. So I'm going to put a little mark here. And I'm bending this back so that, and I'll show you why I'm doing that, but you don't have to. Okay. Now, the next thing I want to do is, it's very important, it will help the ease of insertion if I will take and coil the tube around my hand. That will help give the tube some more flexibility and also help give it that angle that you want. So that I'm going to just coil it around about 3 to 4 inches. And then get that angle, and it will help for the insertion. And then I'm going to lubricate about 3 to 4 inches of the tube. So I'm going to get my water soluble, which is very important, is to have a water soluble lubricating jelly. It's in case they were to aspirate this, it's not going to be as hard on the respiratory system. So I lubricate about 4 inches down. And then I'm going to take, and I'm going to ask the patient to have their head back. But before I do that, this is something that I have found that really helps keep you from making a horrible, horrible mess, is if you will take and you will put the syringe, the 60 milliliter syringe at the end of the tube, go on and put in your 30 milliliters of air that you're going to instill, and put it on the end of the tube, and that way when you insert it, if their stomach is full, you're not going to get all of that coming out everywhere. Of course, your drape is here in place. So you have your drape nice over the patient, just in case you do make a mess. You have your drape there. Okay, so now it's important for your patient to have their cup of water. And of course, my patient cannot hold hers, so we'll just pretend that she is. And now what I'm going to do is I'm going to ask the patient to swallow when I tell her to. But first, her head is going to start out by being extended back against the pillow. And then when I get into her oral pharynx, and I'll know I'm in her oral pharynx because she's going to start to gag. So here we go. Okay, here we go. I know I'm in her oropharynx, so now I'm going to flex her head forward, and I'm going to go down, down, until I get all the way to my tape. And I'm to my tape. And I want to secure temporarily to check for placement. So I'm taking the tape that I had just to temporarily secure it. And now I'm going to get my stethoscope. And I'm going to listen over the epigastric area is what I'm doing. So let me move this all down so you can see. I'm going to put my stethoscope over the epigastric area, and I'm going to instill my 30 milliliters of air. And I should hear a gurgling sound. And I heard the gurgling sound. And then another way to check placement. So one way to check placement is your 30 milliliter air bolus, which is just pushing in the 30 milliliters of air. The next thing I'm going to do is I'm going to withdraw my gastric secretions. And I'm getting some gastric secretions back. And that's the next thing that I can do. And I'm going to clamp this. So the color of my gastric secretions is another method to verify placement. Another way to verify placement is to check pH. And to check pH, I'm going to take my strip and I'm going to put my gastric secretions on my pH strip. And I'm going to verify it, the color, with my pH, and this one is about a 3 or a 4, which would let me know that I'm in the stomach because, of course, in the stomach, it's more acidic. If it was more base, then I know that I might be in the respiratory system. So, but I'm in the correct place. The fourth way that you can verify placement, of course, is X-ray. So you have 4 ways that you can verify placement. Now, I'm kinking my tube to keep from losing any secretions. Now, I have an order for low wall suction, continuous low wall suction. And I have my suction equipment over here, and I've turned my suction equipment on, and I'm going to check it. And I've made sure that it is suctioning. And I have my little extension to connect my suction together. So I'm going to hook my suction to my tube, and I'm just getting those hooked in together. And I've got my suction on, and then I'm going to start seeing that my secretions are going to come out. So my secretions are coming out, and I need to secure my tube better. So I'm going to remove this tape that I had on there and put on this other piece of tape. So I probably got this a little too long, but that's okay. You can tear it off here. Make sure that you do not let go of this tube because it can come undone. So I'm going to just tear this off. There we go. And then I'm just going to loop this around like this. Come back over here. And then loop it around this way. And tape it here. And of course, like with the IVs, you learned there is more than one way. The main thing is that you do not occlude their nares completely. And I'm going to let my videoer here show that her nair is not on either side occluded. She's got air. I see students taping and they've occluded the entire nose. So as you see how I've done that, neither nair and my tube is good and secure. And that is how to put down an NG tube. I've anchored it and I verified my placement. And now I need to document, and of course you need to document the length, size, type of gastric tube inserted, that you confirm the tube placement, that the tube, if it's connected to suction or not, and record the amount of gastric aspirate you got in the color, and how the patient tolerated the procedure.